We can start now, ma'am.
Dr. Seema?
Yeah, okay. So I'm audible and visible, I hope.
Yes, you
Yes.
are.
Very good afternoon to all of you. And it's my pleasure to welcome everybody on behalf of Chandigarh, Punjab, Haryana, Himachal chapter to this very interactive series. And at the outset, I would like to congratulate and thank Dr. Loveleen for making us all, come out of our deep slumber and learn something. So we have now the most learned panelists, the chairpersons with us, who will be introducing our main speaker, the star speaker of the evening, Dr. Sachin Kulkarni. We have heard him in the previous webinar and how his presentations are precise and to the point and evidence-based. So all our chairpersons are also esteemed faculty and they pioneer in the field of infertility. Everybody has got their own fields of interest. So I would like to invite Dr. Sonu Balhara. She is our past Secretary Haryana chapter, and Dr. R.J. Mahajan, who is assistant professor at IGMC Shimla. Dr. Neela Bahati, she is director at Jaipur Hospital, and Dr. Preeti Jindal, director the Touch Clinic Mohali. Dr. S.S. Chawla is the founder of Sanjot Hospital, and he has got special interest in immunology and reproductive endocrinology and PCOS. At same time, I would like to thank all our organizing team chair members who are the chapter secretary for Chandigarh, Dr. Loveleen Sodi, Dr. Surjit Kaur, Secretary Punjab chapter, Dr. Anita Sharma, Secretary Rajasthan chapter, Dr. Yogita Dogra, Secretary Himachal chapter, and the most versatile Dr. Natasha, who's our joint secretary Haryana chapter, and I am Dr. Seema Mittal. And on behalf of ISF Haryana chapter, and over to our esteemed chairpersons to introduce the speaker of the evening, Dr. Sachin Kulkarni. So maybe Dr. Sonu Balara, if she's there, she can invite Dr. Sachin Kulkarni.
Dr. Sonu, ma'am?
Yeah, you can hear me, Natasha?
Yes, ma'am. Yes, ma'am, please. Welcome,
Yeah.
ma'am.
Thank you so much for inviting us to this webinar and the very important talk on frozen embryo transfers. So I welcome Dr. Sachin Kulkarni, who's consultant at Sunanda IVF, Kolhapur. He is the HOD of Fertility and Reproductive Medicine Department, Jahangir Hospital, Pune. He's a teacher at Reproductive Medicine course at Dubai, consultant New Leaf Fertility Center, Addis Ababa, and regularly conducts fellowship programs in IVF and reproductive medicine. Welcome, Dr. Sachin.
Thank you
can
so much.
please
Thank
continue.
you.
Yeah.
Thank you so much, all of you. I'm sorry for my delay in joining the session. Let me just share the screen. Is my screen visible now?
Yes, it is, sir.
Yeah, thank you so much. Firstly, really thank you so much, all of you, for involving me in this discussions. And I was just thinking how to go about conveying the information on frozen embryo transfers. And I just realized that though this is a very new entrant like PGTA in the field of reproductive medicine, there is a huge amount of papers are being published, and most of the papers are coming in last decade itself, ever since all of us started practicing frozen embryo transfers. So I took a special permission of Dr. Sodhi Madam. I requested her that I won't be able to cover up the whole thing in one go and allow me to fractionate it. Today we will be discussing a few evidence papers which are very much important for us to execute your programs, and probably reading these papers will give us that encouragement to solve our troubleshoots in executing a frozen embryo transfer program. As far as protocols are concerned, we will have one more talk later, and obviously that we'll also discuss about the ideal scenarios of doing FETs in practice. this is the agenda which I've kept. It's little mixture of apples and oranges. If it is getting little longish, I would request that after one of the agenda is complete, we can just stop and we can cover the rest two topics at a later date as well, because I really don't want it to stretch for a real long time. So let's go and let's think of discussing a few topics which are there in this agenda. Now, the first is obviously thin endometrium diagnosis. I think it's universally agreeable that all of us diagnose thin endometrium when consistently you're having an endometrial thickness less than 7 millimeter in your patients. And there are various levels at which you diagnose your thin endometrium. You could be diagnosing it on the day of HCG trigger. That's the commonest diagnosis done. But one could diagnose it on the day of embryo transfer. Or, I prefer seeing in my ovulation induction cycles, even endometrium in the luteal phase, whether my endometrium less than 7 millimeter has picked up. And then I take a call whether it is a thin endometrium. But I think one of the most sensitive predictor of diagnosing thin endometrium would be what is the endometrial thickness at OPU. And this is one thing I do in my practice also. They always preserve one film of the sagittal plane of the uterus after I've done completed the OPU and knowing the endometrial thickness, because at that point, if the endometrium is thin and when your estrogen levels are definitely beyond 1000 picograms, we're definitely looking at something which is troublesome, which could make us diagnose thin endometrium in future also. Also, this is an opportunity to have a repeat look at the endometrial cavity. Many a times, I do see sometimes a small polyps here and there, and I keep my hysteroscope ready, and doing hysteroscopy at OPU is one of the commonest practices which I follow. So this is one interesting retrospective cross-sectional study. They looked at different predictors of inadequate endometrial thickness at frozen embryo transfer cycles. And one of the predictors was the endometrial thickness, which was observed at OPU or fresh embryo transfer in the first cycle. And look at the ROC. The ROC is 0.79. So it's a pretty significant with 80% sensitivity and near 70% specificity that if you have a thin endometrium, is somebody echoing? I'm so sorry about that. So if you have a persistent thin endometrium, you have thin endometrium diagnosed at OPU or at fresh ET, definitely that is something which can repeat later, and that could be one pickup point and one sensitive point to educate our clients as well. As I told you, I'm going to jump a few ideas. So I'm going to talk a little bit about how do we define LH search. And all of us, we need to go to natural cycle frozen embryo transfer cycles or modified natural cycles. And before we discuss that, we must define the definition of LH search. And this has been defined variously in the literature. A few studies have defined it as LH level going beyond 17 MIU at any one time. The studies also describe LH level beyond 10, and then they have done repeat levels of a day or two, and it is increasing. LH level beyond 20 MIU is also one of the definitions. Also, I say that if the LH is increased by 180% beyond the basal level, then that should be taken as LH search. Then what could be the best definition? And these interesting studies on defining an LH search were done by Irani et al. And the same Irani et al. Studies have been copied by Human Fatemi and Barbara Lawrence in this study. And they have put forth a beautiful paper of the art of frozen embryo transfer. And this will go back to the nature to do as much as possible the natural cycle embryo transfer. And this is the way they have defined LH rise. So on day one, I'll make you understand the different. Day one, the LH is going high. E2 is high because the follicle is dominant. The progesterone is not yet gone high. As the LH goes high, the LH starts luteinizing the follicles. So the granulosa cells start getting luteinized, and their estrogen production converts into progesterone production. So the estrogen level drops as much as by 30%. But the luteinization is not so complete that the progesterone rise is noted. And on the next day, you will have an LH rise, E2 will be low, and progesterone will rise. If you look at this kind of, you get 3 days investigations to be done of E2, LH, and progesterone, and you make a retrospective diagnosis when LH has risen. And then they looked at it and they said, well, if you notice the drop in E2, that means LH has risen significantly. But there are various studies which have been done about the natural cycle LH search. And believe me, every lady has a different kind of LH surge. We commonly expect the LH surge to go up, then have a plateau and come down. So many women could have just one up and down. One can have a very slow rising LH surge all the way at the time of ovulation. It could be peaking. They could have two peaks. There could be an LH surge which could last as much as 5 or 11 days also. So there are various types of natural LH surges, and I'm sure this pituitary thing is maneuvered by the GnRH, which in turn is maneuvered by the stresses of life. So the different stresses of life could be making a difference there, and that could be one of the reasons why one gets early cycle or late cycle when a lady goes to stress like exams, going to a hostel or getting married, suffering an accident, having high-grade fever, etc. Because of that stress could be altering the LH surge type, and that could give rise to different kinds of menstrual issues or menstrual irregularities. So this is an ideal definition by this particular paper, and I really endorse this because if you follow this particular regimen, you're going to be very nice in when you do your true natural cycle embryo transfers. So coming back to this, we are going to time everything as per our ovulation. So once we know the LH rise, remember one thing, that LH rise does not start the window of implantation, but the progesterone rise does start the window of implantation. So we don't time everything to the LH rise. We want to time also the progesterone rise. So if you're timing it to the progesterone rise, your ovulation is very important. And how do you define the ovulation has taken place? And Human Fatemi in his paper defines, repeatedly he's followed this definition in 2 or 3 of his papers, that when the progesterone is beyond 1 nanogram, you say the ovulation has occurred in the particular scenario which I described. But trust me, there are many papers who have taken the day of conversion to progesterone, the progesterone level less than 1.5, where they have just borrowed that 1.5 from the data which has been published in the fresh embryo transfer cycle studies by Venetis et al. Of 60,000 IVF cycle retrospective analysis, which said that if the progesterone level on the day of trigger is beyond 1.5, clinically or statistically significant drop in the fresh embryo transfer pregnancies are there, and that is an effect on the endometrium taking place. Everybody knows that a high progesterone on day of HCG will alter endometrial receptivity, but one doesn't know what level in which patient. Because a high responder patient, probably a higher progesterone is needed. For a low responder patient, even a value of about 1.2 also can make a significant difference. We must, in our practice, do a natural cycle embryo transfer or modified natural cycle embryo transfer. That is the best. We should avoid hormonal replacement of programmed cycle FETs as much as possible. Unless you're compelled to do a programmed cycle, don't put your foot into programmed cycle. As much as possible, we should do natural cycle. And that's going to be the main ethos of both my presentations, that how we can do natural cycle or modified natural cycle FETs. So this is a beautiful paper on endometrial preparation protocols prior to frozen embryo transfer. And they said is convenience important over the safety? And I think for us, all of us, convenience is not important. Safety is more important. And most of the time, the programmed HRT FET cycle is practiced for the convenience because there's so much of flexibility, so much of scheduling is permitted, and one goes by that. But that's a very unnatural thing to do. And safety of the client is very important. So let's understand this from the safety point of view. And this is an analysis by Bostonelli et al. In 2022. They looked at the studies of obstetric outcomes in programmed cycle FET compared to stimulated cycle FET. And they included a natural as well as a stimulated cycle. And they looked at the singleton as well as multiple pregnancies. And they found there's an increased risk of hypertensive disorders of pregnancy. The odds ratios were 1.6 with the Forex plot to the right side of the line of unity. So definitely, if you do program cycle FET, the chance of preeclampsia is quite high. And the whole theory is the relaxin, which is secreted from the corpus luteum, has a maternal effect. It changes cardiovascular and myometrial adaptation is better. Also, the renal angiotensin system acts better. And so the luteal space is much better. And the maternal adaptation is better. And that's why the chance of PIH is much low. And all these adaptations get restored after the luteoplacental shift takes place. So preeclampsia, but should we take that risk? No, that risk is not for that particular pregnancy. preeclampsia also has a long-term risk to that lady, because the future risk of a cardiovascular diseases like heart failure, hypertension, even type 2 diabetes mellitus is high if she has suffered a preeclampsia in her pregnancy. And most of our women would be beyond 32 years of age till about 45 years of age. As it is, they are at a little higher age, and preeclampsia would definitely may cause them more future health issues. Wu et al. Did a study in 2016, almost went over screening 6.4 million women with about 250,000 preeclampsia patients, and proved that if you do, the preeclampsia risk is related to a heart failure in the future. So we need to avoid it, and that's why ovulatory FET is a must we should practice. But a very thorough RCT is difficult to publish, because if you want to do a thorough RCT of knowing there is a hypertensive disease of pregnancy with program cycle, you need to have approximately about 2,200 patients randomized. At this juncture, these are the two studies which are going on by Shade at Stanford University and IVF Valencia, and you are looking at the N numbers. Those two put together, these are ongoing trials comparing the program cycle and natural cycle to know the eclampsia risk, preeclampsia risk, and probably the results of this will educate us what is the truthful story. Let's jump to another topic, and that's about estradiol level and duration, and that is something which is so dear to us. And we have so many queries on: is my estrogen level is high, low, what is right, and what is the duration of estradiol supplement, etc., etc. So let's look at a few evidence papers which are published in this particular regard. Again, I'm just reminding you, I'm not discussing protocols, I'm just discussing the papers which will give us information to do our day-to-day practice better. This is one beautiful paper, and when the George Bissinger, his group published this up, and they looked at the by the time this paper was published, we were all doing progesterone levels in FET cycles. But when we are doing duphaston or dydrogesterone, it does not reflect as progesterone level. So should we be testing a metabolite of dydrogesterone? So this is a paper which looked at the metabolite of dydrogesterone in the serum level, and they looked at the frozen thaw embryo transfer. But all these were program cycles. So they gave HRT with Progainova for a period of 12 days, took the endometrium to 7 millimeter. Then they shifted on to progesterone, duphaston, and then they did progesterone levels, they did the duphaston level, sorry, dydrogesterone levels, also beta, and a study was published. And obviously, they also looked at the estradiol levels. I really want you to look at this particular graph. On the y-axis is the estradiol level. On the x-axis is the dydrogesterone level. And all the dots, which are black in color, are the pregnancies obtained. Now look at the circle which I'm pointing you at. In those circles, there hasn't been a single pregnancy noted. So what does this say? It says that a certain amount of estradiol level is necessary to get an optimum outcome. And this study really conveyed that. So if your estrogen level is low, obviously the endometrium is not great. Secondly, the progesterone receptor induction may not be good. And maybe these two reasons are responsible for not getting any pregnancy. So this paper really told us this particular story, that a certain amount of estrogen is necessary to achieve pregnancies in our program cycles. Now, whenever we are giving dydrogesterone to all our patients, we must tell them that they must take it with food intake, because there is good amount of enterohepatic circulation, and this is a steroid, and it will get absorbed again and again because of enterohepatic circulation, and higher levels of dydrogesterone will be achieved. So whenever I request my clients to take duphaston, it's always after food. This is another paper of impact of estradiol levels on pregnancy outcomes in letrozole stimulators. See, when we give letrozole, we will be giving it from day 2 to day 6 or day 3 to day 7. Some people also give a long letrozole cycles, extended letrozole. So there would be low estrogen level in those particular cycles. Secondly, once the letrozole stops, it's about 48 hours of washout time by the time the estrogen level goes up. But it is not a very strict washout time. There will be a subgroup of women not yet been identified by any predictor maneuver, that who will have a higher washout time. We don't know about it. And even I have found that when I've given a letrozole from day 3 to day 7, the client comes to me on day 10, I see a very good endometrium, but when I do an E2 level, that could be 70 or 80. And I'm not sure. Looking at the earlier paper, I needed a good level, but at the same time, the letrozole stimulated cycle, it is an iatrogenic low level. Should I be considering it as important or not important? So I looked at this particular paper, and it does say that they had two groups in women who had an E2 mean E2 of 66 picogram. Another group of mean E2 was about 300 picogram, and low estradiol level was associated in this particular study with low live birth rate and increased miscarriages. So nowadays, what I do with letrozole is I tell the client to start the cycle on day 1. So though the client comes to me on day 2, I tell them, please start your letrozole on day 1 itself. Come to me on day 2, I do a baseline scan, and then I call them on day 9, day 10. By the time her letrozole is over by day 5, and even if she comes on day 9, 4 days I feel practically is enough for me to have a letrozole complete washout, and probably my estrogen levels, which I do in the lab, will be reflecting the truthful story. Now, suppose this is a very interesting paper published way back in 2021. I'm thankful to Dr. Sharyu for sharing this particular paper to me. And this paper looked at a natural cycle. They looked at it is not the estradiol level, what we do is only a snapshot. Is that snapshot estradiol enough, or we should know a trajectory of a estradiol level? And this paper beautifully says that if the estrogen level is beyond 100 picograms for more than 4 days, they had the best pregnancy rate. So this can, if I go back to this particular paper and if I understand both the papers, what I feel is with letrozole, your E2 level is going to keep low. And if it peaks up, but if it has peaked up just yesterday, and today your level is coming to, let's say, 105, and if you're less 105 level, good beyond 100, the endometrium is looking good, let's go ahead and give a trigger, and probably that may be inadequate. So we need to have our patients to have probably another day maintain the estrogen for some more time. These are all retrospective studies, but we are doing our prospective practice. So implementing a retrospective study in a prospective practice, we do face issues. I'm not denying that. But this paper is also telling me that whenever we do stimulated FETs, our estradiol levels peak up, and we commonly give trigger a little early, or there's a much earlier conversion. Nowadays, it's been my favorite to go true natural when I know the menstrual history of a lady, and that gives you a little good amount of time, because then you're going all the way to day 13, day 14, or day 12, and by the time the estrogen has done much better, I feel. So probably all this information of these papers is telling me to go true natural and give only HCG trigger, not give a stimulation cycle unless a lady is anovulatory. Now, what about the impact of serum estradiol concentration prior to progesterone administration on live birth rate in single vitrified warm blastocyst transfer? Now, this is a very beautiful paper. Single vitrified warm top quality embryos were transferred in this particular paper. They did not do euploidy studies. So they had anticycles. It was the first FET cycle they looked into. They used HRT, that's program cycle protocol, about 468 cycles. And they made 4 quartiles, depending upon the percentile of the estrogen level. Less than 25th percentile was estrogen between 64 to 200, then 200 to 256. Beyond 50 to 75 percentile was 250 to 76, 376, and group 4. Look at the group 4. They have run all the way to 1,449. And there are outliers in our practice that when you give program cycle, some of the clients could be outliers and they would have a very high estrogen level, and we get confused. Should we be doing a transfer or should we not? And this particular paper says, well, it doesn't make any difference. Your clinical pregnancy rate, your multiple pregnancy live birth rate, everything remains same, irrespective of the estrogen level on the day of progesterone conversion. So this really gives us an assurance to go ahead and use this in our practice. So they looked at the ROC, the area under curve, it was 0.49 and 0.51. So it is not significant at all. So estrogen level is not a discriminatory power, doesn't have a discriminatory power to decide on the clinical pregnancy rate or live birth rate when used in a program cycle in a range from 64 to 1,446. But so this says that only endometrial thickness and serum progesterone should be enough to take a decision to transfer, and you would be right. But if you look at the trials which are published earlier, the trial by Fritz et al. In 2017, they said E2 affected the results. They said that when the E2 is very high, the results were low. But this study was very heterogeneous because they used day 3 embryos also, day 5 embryos also. They also did single embryo transfers and double embryo transfer. While in this particular study, which I'm quoting now, which doesn't make a difference, they only did a single top quality blastocyst, morphologically top quality blastocyst than Fritz. So I think this study will have more power. But there are many other papers published by Ni et al., Boca et al., Banz et al. They have proven that there is no difference in E2 level and pregnancy rate. And all these studies definitely tell us that you can forego with E2 test, but if you're doing it, don't get worried about it. Now, this is a beautiful thing, I feel. If you go through this particular study by Rock in 2017, he looked at the estradiol levels in fresh embryo transfer cycles. And we will do fresh embryo transfer cycles only in low responders. So he also did the same when they got 4 to 9 oocytes. And what is the E2 level then? The E2 range is 1,470. So this, and you still do a fresh embryo transfer cycle and hope for a pregnancy. So even if you can see an outlier patient, when you're doing programmed embryo transfer, giving high doses of Proginova, if an outlier patient has an E2 beyond 1,000, don't get worried. You can still utilize that cycle for embryo transfer. And that's what all these evidence papers are giving information to us about. Now let's come to the duration of estrogen supplementation. What should be the duration we should target? Here I must add a caveat. I've read many papers on this regard. Our papers were not talking about the duration of estrogen, but talking about frozen for embryo transfer. Many papers are saying that if you're given for 14 days, in 14 days they could not get a 7 or 8 millimeter endometrium, they have cancelled the cycle. Whether that is a part of their practice or whether there is a part of the protocol which they used to publish the paper, we are not aware about it. But herein, I gather, in our scientific fraternity, most of us agree that the endometrium should develop with certain amount of estrogen duration. If it is developing after a longer estrogen duration, probably we are not looking at a great endometrium. That's what logically we feel. But let's look at the studies here. Again, a single blastocyst transfer cycle here, which has been studied. Just allow me, my voice is cracking because I've suffered a laryngitis recently, just recovering out of it. Well, this paper looked at the estrogen duration. Look at that, 11 to 14 days, 14 to 18 days, and beyond 19 days. And the live birth rate, clinical pregnancy, the miscarriage, everything the same. So this paper tells you, if you're doing a morphologically good quality blastocyst you're transferring, your duration of estrogen wouldn't make a difference. Supraphysiological E2 levels do not adversely affect the pregnancy rate. E2 duration or estrogen supplement duration of 11 to 30 days to achieve an ET beyond 7 millimeter does not affect the pregnancy rate. And that's what these evidence papers are telling the story to us about. Again, this is another paper, but this is the other way around. This says prolonged estrogen treatment prior to FET decreases live birth rate. And this is what I feel is the beauty of our reproductive medicine. Because papers are published on either side of the story and one gets confused. But look at, I always, in such a scenario, I'll always tell all my fellows, look at the materials and methods, don't look at the conclusion. And this is a material method could be entirely different, creating an heterogeneity. And then you say, what material method you are practicing, is it applicable to you? So in this particular say, only E2 exposure beyond 36 days. Does it apply to my work? Hardly any patient I remember where I've given estrogen beyond 36 days. So even if this paper is published, I wouldn't take it at a face value because this is not my clinical practice. Now, this is another paper, and I always like this particular papers nowadays who talk of euploid blastocysts because we all have shifted to PGTA whenever we face patients beyond 38 years, and we really want to know about papers published onto transfer of single euploid blastocysts. And this particular talks of that for the endometrial preparation. And this said mean E2 duration was, supplement duration was 17 days in a program cycle, the range between 10 to 34 days. And it says if you're doing a single euploid blastocyst transfer, the duration of estradiol the supplement does not impact the outcome. But if you have a shorter duration, less than 10 days, chance of miscarriages is high. I think nobody is doing it. We all do beyond 10 days anyway. Now, This is another scenario which comes into our practice, wherein we halfway through, call the patient on day 8, day 9, we find we're not happy about the endometrium, and we step up the dose of estrogen supplement. So this is a beautiful paper, again very relevant in our practice. That does increasing estrogen dose during the FET affect the pregnancy rate? And there are about 5,400 cycles. 87% they were on 6 milligram fixed dose. About 13% of the client needed an increased dose, and clinical pregnancy rate 34% in the fixed dose, 35.8 in increased dose. So no difference. So you are welcome to increase the dose halfway through, and there will not be any difference in the pregnancy rate. Now, what about the route of estrogen? Shall we be giving oral alone, or can we use vaginal estrogen? So this is a beautiful paper again. So I try my best to go through papers, understand the materials and methods, and put it to my practice. But that gives you so much of strength, and mentally you feel much comfortable doing this kind of practice, just rather than hearing and hearsay. So this is about oral and vaginal. And what they did was, they gave oral preparation to most of them, everybody rather. If the endometrium was not achieved, they added vaginal later. Or you could be doing oral and vaginal combination, as many of us could be doing in practice. And this again use estradiol valerate only. That many of us use estradiol hemihydrate vaginally, but they have used estradiol valerate only vaginally. So that when the endometrium is lagging behind, let's say 14 days, the endometrium is not 7 millimeters, you are welcome to do vaginal addition. And it does reach the endometrium directly. It does make a difference to endometrial transfer, but don't be in a hurry. Give 5 to 7 days. Don't expect a result in 2 days. It takes a longer duration for vaginal estrogen to act. So if you're using only vaginal preparation of estrogen to prepare endometrium, then please use it for a longer time. Even if you go for 16, 20 days and you have endometrium prepared, then still it is okay. It definitely avoids a first pass effect. And look at the estradiol valerate, only 5% will dose what we give after the liver first pass effect reaches the circulation. So it's a pretty small dose which goes there. I'm taking a pause here. Any questions onto this? Because I'm going to a next topic altogether. Am I audible?
Yes, sir.
Okay. So can I continue, madam?
Yes, sir. There's just one question. Does the E2 levels in HRT FET in good cases of good ET and good vascularity also to be done, needs to be done?
There is no need. All this evidence is saying the same thing. There is no need to do E2 levels.
Right, sir. Right, sir. Thank you, sir.
But when we practice evidence-based medicine. We also practice consensus-based medicine, and we practice value-based medicine. And when it comes to consensus-based medicine, look around you, the clinics. Are they doing an estrogen level? If it is a consensus that everybody is doing estrogen levels, nothing wrong in doing one as well. So from the consensus-based practice point, one could be right. Okay, let me come to the next one. Now, we always used flexibility and scheduling purposes, our cycles or program cycles. Very, very doctor-friendly cycles could allow us to enjoy our Saturday, Sundays, and could allow us maneuver the things around our conferences, etc. And natural cycle FET and MNC FET, like modified natural cycle, does it allow that flexibility and scheduling? So we go through a few papers, how it is permitted. I faced this issue myself 3 years back when I joined Jahangir Hospital. So every week, 2 days, I'm in Jahangir. So I was worried, will I have to shift to program cycle completely? But trust me, 90% of my cycles today are natural cycles and modified natural cycles. I hardly do program cycles unless it is really mandatory. So when you do natural cycle FETs, could be a true natural cycle. You're dependent on the LH surge provided by the nature, or you could be giving an HCG trigger, or you could be adding a progesterone level and a follicle reaches the size of 17 millimeter. So let's understand what options are available with us so that we can act on those options and have scheduling of our natural cycle frozen embryo thaw cycles. So this is one paper published in 2024 on natural proliferative phase frozen embryo transfer cycle. And I think this paper with the first round is not yet published, but I remember one of the Abbott meetings I had attended, and fortunately George Bissinger was present there, and professor was proclaiming this particular protocol. So what he did in this particular protocol was, he said, just leave it to the true nature, call the patient on day 10, after you do day 2 scan, confirm that ovary is acquired, on day 10 onwards, once you find a follicle which is going beyond 16 millimeter and the endometrium is reaching 6 millimeter and above, you just start the patient on progesterone. So he would say just start the patient on the first one, 30 milligram a day. So we start a patient on progesterone directly. So you're converting that natural cycle into a program cycle now. You're adding the progesterone, add 5 days of progesterone on day 6, you do an embryo transfer. Let's understand the basis of that particular theory. So this was a protocol. On day 8 onwards in a true natural cycle, they measured the embryo ET, so beyond 7 millimeter, and they started on vaginal progesterone. This is not the single study. This is the study I'm quoting you. The single was the communication which I quoted to you. 400 milligram twice a day, and and they look at the cutoff. They took a cutoff of progesterone level less than 1.5. We commonly take less than 1 as by human fatigue. Regardless of follicle diameter and serum LH level, they just put the patient on progesterone, and the blastocyst was transferred on day 6 of the progesterone start. And they looked at the serum progesterone levels on the day of ET. See, they also looked at the serum progesterone level when they started the progesterone, which was less than 1.5, and they looked at the progesterone level. This progesterone will be coming from the progesterone which you're supplying, and also by now the follicle would have ruptured. So the corpus luteum is also secreting progesterone. So it will be endogenous and exogenous mixed progesterone level. And if that progesterone level is less than 8.5, they did an embryo transfer, but they added an intramuscular progesterone oil. They started on alternate day later. That was the protocol which they followed. And now look at that. Look at that. They had a comparative study of NPP, that is your natural cycle, directly added progesterone, and true natural cycles. And look at the clinical pregnancy rate. Clinical pregnancy rate in natural cycle is 57%, and the reference is 54%. That was pretty good. The miscarriage rate is also low, and the live birth rate is also fine. So you can do this. So to give an example, let's say the client has come on Monday to me, and in my consulting, I find a follicle about 16 millimeter, endometrium is beyond 6 millimeter. And if I give a trigger to her, or let's say the patient has come on Sunday. If I give a trigger to her, next Sunday is my transfer of blastocyst, but I'm not available. So I will put the patient on progesterone from Monday or Sunday itself. So Sunday, Monday, Tuesday, Wednesday, and Thursday she takes progesterone, and Friday I can do an embryo transfer and I'm available on Friday. So that flexibility is available here. This particular thing came from this paper. Okay, the luteinizing hormone independent rise of progesterone as a physiological trigger for ovulatory gonadotrophin surge in human. Let me go back and tell you that many of us in our practice, we commonly see women who have come to us with the first kid in 10th standard already. And, she comes with amenorrhea. And we said, okay, your pregnancy test is negative. You take a primal lutein and you'll get period. And she doesn't come for 10 more days. And after 10 days, she comes out. She says, I've not got period. And she's pregnant. So what has happened is she's anovulatory, a dominant follicle is there, it is secreting only estrogen. You give progesterone, and that small amount of progesterone triggered the LH surge. So it is not the estrogen which triggers the LH surge. A rise of estrogen is necessary, but it is a small amount of progesterone rise which clicks the LH surge, and that causes a rupture. And that whole theory is used in this particular philosophy of giving progesterone addition after a dominant follicle is there and then doing an embryo transfer. So progesterone is very low and stable in follicular phase. It allows progesterone to accumulate and progesterone receptors to be sensitized. Because there is lack of progesterone, progesterone receptors are hungrily waiting right from hypothalamus, pituitary, everywhere. So even if the progesterone rises in a very narrow window, 12 hours prior to ovulation, that will trigger the LH surge. So LH surge is triggered by progesterone rise at the end of follicular phase, and that physiological thing is used by the earlier protocol. And this is a beautiful paper again. It's a nice study by Alonso. It's highly quoted. Many of when you go to any conference, this particular study will be put forth to you. And he did an analysis, retrospective analysis, and looked at all the data. And when the follicle was 13 millimeter to 22 millimeter, they had given HCG. And provided the endometrial thickness is gone 7 millimeter, and then they looked at the pregnancy rates further. So, contrary to a true natural cycle, a mature follicle is not necessary for a modified natural cycle. What you need in a modified natural cycle is a follicle which is secreting enough progesterone. So if there is UHCG, which is act on the cyclic AMP pathway, more steroidogenic, so it will secrete progesterone from the follicle. On top of that, anyway, you're going to give some amount of testosterone or vaginal progesterone. So a functional corpus luteum secreting estrogen progesterone with vasoactive substance, good enough, he says. And he looked at the data from follicle size of 13 to 15 millimeter, 16, 18, 19 to 22 millimeter. And they said similar clinical pregnancy rate, miscarriage rate, and ongoing pregnancy rate in all three groups. So irrespective of the follicle size beyond 14 millimeter, if you give HCG trigger, so you can schedule it. So on Sunday, let's say the client comes on Monday. Monday, the follicle size is 15 millimeter. If I give a trigger, the transfer is next Monday. If I wait for another 2 days, I'm having an HRA conference starting next Wednesday. I'm going for the conference. So I better give trigger at this now and do a transfer on the next Monday. So this is schedulable, and that's what information this paper is giving. And the mean follicle diameter, look at the area under curve, the mean follicle diameter is not a discriminatory factor from clinical pregnancy rate. So it's all the same. And this is the way a calendar, which you can keep it in front of you and describe, if you do HCG today, what are the flexibility you can get. Let's say Sunday, the follicle is 15 millimeter. You want to give a trigger. The patient says, give me a trigger today. Endometrium is 97 millimeter. You do LH to progesterone all within normal limits. You can even wait for a day, give it tomorrow, and then do a transfer the next Monday. So flexibility can be offered by this kind of a maneuvering as well. So I'm telling you two maneuvers to achieve your flexibility: vary the HCG injection or directly add on to progesterone. But we need further studies on prenatal outcome. Perinatal outcome studies are needed, confirming is the corpus luteum of a follicle of 20 millimeter same as a corpus luteum of 15 millimeter? That's a question we should ask, because we don't know the amount of vasoactive substances, relaxin is secreted is enough. So unless we have a perinatal studies published onto this kind of a flexibility, we need to know it further. We won't be able to practice it very flexibly. And will a protocol like this, like triggering at 14, 15 millimeter, reduce a chance of gestational hypertensive disorders? Now, these things are not yet being published. Any questions onto this flexibility before I go to endometrial compaction topic?
So yes, there are questions. What about adding the antagonist along with the gonadotropins in case of MNC FET to program for few days? And does
Excellent question. Yeah. Let me answer this. So we are talking here of a stimulated FET where you are giving gonadotropins, and can you give antagonists? Yes, you can give. From the logic and physiology, it does appeal to me. I've not come across many papers onto this particular thing. So let's next time I'll come to you with if any evidence has been published. Do I do this? I use a very minimal gonadotropins to my stimulation. So I generally don't do addition of anta, because I feel if you add anta, you'll have to add gonadotropin, continue the gonadotropin. That's going to increase the cost of treatment as well. So I'm a little skeptical, but you can do that. Physiologically, it appeals to the physiology, no doubt about it. Next, any more questions, madam?
So these papers mentioned 7 mm as the minimum endometrium.
Correct,
so in
correct.
your practice, are you happy with 7 mm? I feel very nervous if I don't go till
Absolutely. So I'm not covering the topic of endometrial thickness. We'll cover it next time. But all the data which has been published, which says that every 1 millimeter increase in endometrial thickness beyond 7 millimeter, there is an increasing pregnancy rate till about 11 millimeters. Ideal, the mean comes to 9 millimeters. So we should target 9 millimeter, no doubt about it. That is one. Number two, you can still, the pregnancy rates keep increasing beyond 11 millimeter till 14 millimeter, but the chance of biochemical pregnancies increase. Because when you do endometrial embryo transfer in a thicker endometrium, the endometrium could be really fragile and it can be injured even by your catheter tip, and probably the biochemical pregnancies. This is a hypothesis which has been put with biochemical pregnancy rise could be there. So I'm going by the Ruffle study nowadays, which talks about having an endometrium beyond 7.5 millimeter, having a triple line, and having a outer vascular layer of 50%. So it's called 1A alpha. We will have that slide in the next talk when I do next week or whatever scheduling we'll do. I'll have that slide. So I do go by a higher than 7, but these are the studies which are quoting anything beyond 7. Any other questions there?
So there's one more question that in modified cycle, does the day cycle matter from when we can start the progesterone?
So herein, if I'm not mistaken, we are a question is we are doing a modified natural cycle, so we're giving HCG trigger. So when should we start progesterone? Okay.
Or maybe she means this person means NPP, the natural progesterone
Yeah,
proliferative.
both are different. Yeah, if it is NPP, you start the progesterone, and the day you start the progesterone, you start creating the window of implantation. So the calculation is very simple as per the program cycle. But if it is an MNC, modified natural cycle, where you're going to HCG trigger, it's like an HCG today, day after tomorrow's pick up. So day after tomorrow is your day 0. So if HCG today, from tomorrow you have to calculate the 5th day, and you will be doing a day 3 transfer. And from tomorrow you have to calculate the 7th day, and that's your blastocyst transfer. I think we will cover this when we do the next talk.
And probably, sir, the question asked is that how many days of what minimum cycle day it should be? Should it be minimum day 10, minimum day 9, or minimum?
No, it is the follicle size. It's a follicle size. The follicle should be beyond 16 millimeter.
Cycle day does not matter.
Doesn't matter. Obviously, all these follicles will be beyond day 9. Hardly anybody will have a day 7, 16 millimeter follicle. And even if it is day 7, we wouldn't take these decisions. We generally have a follicular phase of 10 days or more.
Usually. We can carry on, I think, sir.
Is it okay?
Yes, sir.
Okay. So we'll just discuss about endometrial compaction. A lot was talked about these things. This is a beautiful paper, very recent paper, a meta-analysis of endometrial compaction to predict pregnancy outcomes in patients going ART. And this is that the Haas et al. Paper in 2019, they said about progesterone-induced absolute decrease in the endometrial thickness from the end of estrogenic phase and to embryo transfer, and that they defined it as endometrial compaction. So what happens is there are two different phases of endometrium. One is proliferative phase and one is maturation phase. In maturation phase, endometrium is not proliferating. In proliferative, it is not maturing. So proliferation goes ahead. With compaction, there is increased glandular development. There is inflow of the immune cells. There is more angiogenesis. So there is increase in density, but not volume. That's what it says. There is a very poor correlation between endometrial compaction and actual serum estrogen and progesterone levels. So never have this confusion in mind. Endometrial compaction is a morphologic change which you see on ultrasound, while estrogen progesterone level is a complete different story altogether. Serum progesterone again do not reflect the endometrial levels anyway. So on top, progesterone receptor population and progesterone resistance, which we don't know about this particular patient, which does not allow a correlation of your serum levels and the compaction. So there are a lot of papers, almost 21 studies of 27,000 patients were involved. Most of the studies were good studies. There are papers which say that endometrial, there is no correlation, but there are papers saying there is a positive correlation. And this all started off, believe me, with one publication published by Robert Caspel, and he titled it very beautifully. He said, "Why euploid embryos do not implant?" And everybody started reading that particular paper. But actually, the paper talked about endometrial compaction. It says when the compaction is not beyond 1 millimeter, the chance of pregnancy is low. And then people started investigating this issue further and further. So look at most of the papers are published beyond 2020. Hardly any papers before that. Well, it doesn't make a difference. Now, why? This is not a complicated slide at all. You just say when live birth rate with endometrial compaction and no endometrial compaction, there hasn't been a difference. These are the different definitions of compaction. Beyond 5% decrease, beyond 10% decrease, beyond 15% decrease. Well, whatever definition you use to call endometrial compaction, it doesn't make a difference. You can do embryo transfers. So they looked at fresh and frozen, again, no difference. They looked at euploid embryo transfers, no difference. With the modified natural cycle or its program cycle, no difference. So endometrial compaction is not something to be looked in our practice. We can just forego and do your embryo transfers. We're going to the progesterone levels. Any questions, or can I, madam? They're going to be progesterone level papers and papers on estrogen level. Shall I continue? Shall I stop?
Yes.
What would be your advice?
So
You
please
can continue.
Continue. I'm just getting more sensitive that it is taking more time. That's why probably.
I guess we can continue, sir.
Okay, you just feel free and let me know.
Right.
Yeah. So we're going to talk about the progesterone levels, and this is again a new entrant. George Singer has recently, in 2025, published a beautiful paper. He says that in that paper, he says, the whole FET concept entered as a backdoor, and the program cycle was another backdoor. And now we are, debating so much in conferences about how we should normalize our frozen thaw embryo transfer. The whole focus has shifted from our stimulation to the frozen thaw debates on the frozen thaw embryo transfer cycles. So let's talk about the progesterone levels and what we mean. I'm just trying to quote a few papers, and there are, two different scenarios in practice. There is an American scenario of giving intramuscular progesterone, and there's a European scenario of doing vaginal progesterone alone. So Americans keep blaming that this is not adequate, and Europeans say you are unnecessarily troubling your women. I think I forgot the author. That lady published a tri-study on intramuscular progesterone, vaginal progesterone, and a third arm of vaginal and intramuscular together. And there were methodological flaws in the interim analysis. So that paper, Levin shows the name, and Kate Levin, that's the name. And the whole result was not imbibable. And they had a repeat publication later. But this debate about intramuscular and vaginal progesterone still carries on. So IVF Worldwide did a world IVF survey of about 157 centers. I could be wrong on that number, it could be 180 centers also. And they said that 80% of the centers use vaginal progesterone alone. So vaginal progesterone alone is practiced by many centers all across. But in India, fortunately, we use both vaginal into parenteral or vaginal into progesterone. And believe me, we are truthfully right beyond the Europeans. So first, this is a paper in 2018, because we understand the progesterone levels have a diurnal variation. So it is low now, it could be high later. So this is a beautiful paper where they looked at the progesterone levels throughout the day. Look at the timeline. Every half an hour they have collected blood. Now, who is there to do such studies now, I feel sometimes, But Peter Humaydan did this beautiful study, and he said, if the progesterone level is low, it does not have much diurnal variation. Look at the 3 lines lower down. But if the progesterone levels are high, they have a fluctuation. So when the progesterone level comes less, that means it is truly less for that particular lady. This is what information we are getting from this particular paper. Lisa Thompson and Peter Humaydan also published studies on progesterone levels and the pregnancy rates later. Now, this is another paper. This is also a beautiful paper. It talked about the serum and endometrial progesterone. When we say progesterone level in the blood, what is the endometrial progesterone? Is the progesterone level in the blood reflecting the endometrial progesterone? So this publication, they did proginova, they took the endometrium to 7 millimeter, then they added vaginal progesterone 400 millimeter BD. After day 5, day 6, they did a biopsy. And in the biopsy, they also did serum progesterone levels. In the biopsy, they did progesterone level in the endometrium. They did an ERA test, also was done. So they looked at the progesterone metabolite, that is 17-alpha hydroxyprogesterone endometrial level. That's a metabolite of progesterone, which makes the endometrial changes. They did an ERA test, and they looked at the serum progesterone. And they looked at all these things. And what did they conclude? They said that when the serum progesterone level is less than 8.8 nanogram, receptive ERA was still seen in 37% of the patients. And when the serum progesterone was beyond 8.8 gram, receptive ERA was seen only in 41% of the patient. So your serum progesterone level is not talking about the receptive ERA by this particular criterion. And higher amount of receptive endometrial receptivity on ERA testing was seen when the endometrial progesterone level was beyond 40 microgram. We sadly don't test it because that is a research tool alone, and we can't be testing it lively in any particular scenario. We just assume, we take surrogate markers of serum progesterone or our endometrial thickness of endometrial maturity and such. This is one beautiful paper. I'm going to send all these papers on this group. Please go through as your time permits. This is one beautiful paper and just an eye-opener. And this was so much of a need of this paper being published because there was so much of debate about these progesterone levels, and we really wanted to know what is this progesterone, what is the pharmacokinetics of this particular progesterone, what we are using. And so most of the cutoffs of the progesterone, like Elena Labata study, are deduced by vaginal progesterone, and they did serum levels. And we understand that vaginal progesterone administration is a rate limiting step for absorption of progesterone. So, they did beautiful studies earlier where they give 800 milligram of progesterone vaginally and 1200 milligram. Trust me, the 1200 milligram population has a lower serum level than the 800. So the vaginal progesterone goes up, but after a few days, the levels do drop down. Now, so vaginal progesterone absorption depends upon the microbiome, sexual activity, infections there, and how deep the progesterone tablets is inserted, so on and so forth. So there is a gap in literature on intramuscular progesterone and the serum levels. So chemi-immunofluorescent assay post-purification are the most correct nowadays of doing serum progesterone levels. And without purifications, will overestimate progesterone. So what kind of progesterone assay you're using is also very important. Intramuscular progesterone, if you give, you achieve a steady level by day 6. With vaginal route, the progesterone level peak at 2 to 4 hours later. But later, as you go supplying, the progesterone level can fall down. And in Wu et al. Study, with 45 to 90 milligram of Crinon gel once a day, the progesterone level they could achieve of 10.6 nanogram at 6 hours. It's a variable, progesterone levels are very, very variable when you use vaginal progesterone alone. Even endometrial tissue progesterone concentration is highly protein bound, and only free portion acts on the receptor. Now, let me tell you this why. So, progesterone anywhere in the body is bound to corticotropin globulin. Okay, so corticotropin serum globulin is there, and it's about bound by 40%. About 60% is bound to the albumin, and only 1% is free. That's what it said. Unlike your testosterone, which is bound to SHBG, 90%, 9 to 10% to albumin, 1% is free. But progesterone is bound only to 40% to corticosteroid binding globulin, which is synthesized from liver. So depending upon how much is bound there, a free portion will be decided. So your corticotropin binding globulin concentration is going to decide how much free progesterone is available in the endometrium to act on that. And this could be one of the reasons why serum progesterone does not correlate with the endometrial progesterone and ERA. So corticosteroid binding globulin is bound to progesterone. If you have a patient with decreased serum progesterone, it will have increased expression of corticosteroid binding globulin in the endometrium. So the progesterone level is low in the serum. So corticosteroid binding globulin is overexpressed in the serum as well as endometrium because it is free. And now the endometrial progesterone will be bound to corticosteroid binding globulin because which is high because of the low serum estrogen, progesterone, and now free progesterone, which has a target action, will be low. So are you understanding this? So let me put forth in a different manner. If you have a high serum progesterone in the blood, it will be bound to corticotropin binding globulin. So all the corticotropin binding globulin is satisfied. There is hardly CBG available in the endometrium. So whatever progesterone is there, and now in the endometrial level, it is free to act on the receptors. Now we are understanding why a good serum progesterone level is necessary in the serum so as to have a better endometrial progesterone level. A beautiful paper really gives a different glimpse into the whole thing. Oh, sorry, I was wrong. I told you 40%. It's 20% bound to corticotropin binding, 80% to albumin, and this is how it is. And let's think of beyond this. How the orchestra of reproductive medicine is so beautiful that you have a high amount of estrogen. A high amount of estrogen will synthesize corticotropin binding globulin, and your CBG will go up. So CBG is only 20%. So estrogen will keep varying the amount of CBG there, and that orchestra will go ahead. Now, this is again a beautiful paper about effect of randomized progesterone concentration on secretory endometrial histologic development and gene expression. I like this paper because they not only look at the histology, they looked at the gene expression studies. And they looked at varying progesterone concentration on endometrial histology and gene expression in normal women. And they did histology by noise criteria. We did read noise criteria in second MBBS, 1950 ka publication. And they did microRNA gene expression test also was done. And they said that if when the progesterone dosage is low, the histological dating differed by 3 days. So when they gave 40 milligrams of progesterone, There is not much difference in the histology. While when they give a lower amount of progesterone, there was histological dating also started differing. So and also the gene expression changed. And I think this is the most direct evidence that abnormally low progesterone will result into delayed endometrial development. And histological development may continue, maybe a little similar between 5 to 10, but with 5 to 10 milligram of progesterone. But gene expression is distinctly different at lower concentrations of progesterone. And if we want a better gene expression, better receptivity, we need to have a good progesterone level in the blood. Not only a HOXA10, which is an implantation-specific gene, which is decreased in endometriosis patients and adenomyosis patients, and this is optimally expressed only when there is a high progesterone level. Look at the 40 milligram, that has the highest expression of HOXA10. So we need to have a good amount of serum progesterone so that we have a better endometrial progesterone levels and a better results. So what is the role? We use vaginal progesterone, yes, we must use it because we could need good endometrial levels. It is to kickstart implantation. But for maintenance of pregnancy, you need a good serum progesterone. So we need both a high good progesterone level in the blood and a good vaginal, good endometrial. But endometrium is not measurable. So we can't go away by not giving vaginal progesterone. We will be giving vaginal progesterone and also either a defastrone, which is not measured as serum progesterone, or you can give your intramuscular subcutaneous progesterone to maintain a progesterone level there. The paper on effect of different levels of progesterone on day of frozen ET on the clinical outcomes is published by Middle Eastern Society. I'm purposefully putting this paper here. Why? Because the question commonly asked in many WhatsApp groups is, what about a very high progesterone level? Suppose progesterone level is very, very high on the day of embryo transfer. Should you be doing it? So this particular paper says that, well, if progesterone level on the day of transfer is high, well, they would have a drop in pregnancy. They did notice a drop in pregnancy rate. And high progesterone may have an earlier window of implantation. And they say that their embryo is still developing, the uterus is not ready. So what are the different studies? There are different studies reporting high progesterone, which is detrimental to pregnancy. And different cutoffs. The Coffina study said that, UVIC study said that progesterone beyond 30 nanogram. A licensed study said progesterone beyond 32. Hosseini study said progesterone beyond 20. So the literature is not giving you a complete cutoff. At this particular high progesterone, you will not be doing an embryo transfer. And believe me, when you do modified natural and using HCG, your progesterone levels go really, really very high because HCG is a cyclic AMP pathway progesterone producing hormones. So one of the bases of this physiology is faster rising progesterone reaches higher levels and induces a faster endometrial implantation window. And implantation window will shift as is shown in the green, where the light blue is an actual window, implantation window, and that could be the reason of a little amount of asynchrony created. Now, let's go ahead. But will a systemic progesterone levels in a true natural cycle, if you're doing a euploid embryo transfer, will it predict ongoing pregnancy rate? So this is, again, as I told you, we are shifting to euploid transfers. So let's look at this particular paper. It said it doesn't make any difference. So whatever may be the systemic blood levels, you look at the bottom line, it's less than between 5 to 10 nanograms, 10 to 15, 15 to 20, and more than 20 nanograms. If you're doing a euploid embryo transfer, well, it doesn't make a difference. Now, why this issue? Like, why this particular paper saying it makes a difference, and while euploid embryo transfer says it doesn't make a difference? The answer, I feel, lies in the physiological understanding that where does the HCG come from? HCG comes from syncytial trophoblast. But trust me, even the blastocyst secretes HCG. So a morphologically good blastocyst or a euploid blastocyst, or let's say a so-called implantable blastocyst, by whatever criteria, probably secretes a better HCG. And that HCG molecule secreted by a good embryo is a hyperglycosylated HCG. And this HCG directly acts on the endometrium, making the endometrium better. So does HCG make endometrium better? Let's look into a paper into that. So this particular paper, again, going back to this story, that progesterone level do not make much of a difference. So is human chorionic gonadotrophin directly involved in the regulation of human implantation? I love this paper. old publication, but beautiful one. So euploid blastocysts could be secreting that HCG, which will act locally to improve implantation. That could be the basis of difference. So HCG decreases insulin growth factor binding protein 1. So IGF-2 level increases, making the endometrium better and a better endometrial receptivity. VEGF goes up, leukocyte inhibiting factor goes up. So trophoblast differentiation, angiogenesis is better. So HCG definitely makes a difference on the endometrium directly. And this could be the reason why HCG secreted by the embryo itself could be making a difference here. What about low progesterone levels on the day before the natural embryo transfer can be negatively associated with this pregnancy rate? Yes, that is true. It's a retrospective study. They looked at the serum progesterone measurement between 8 to 11 a.m. Now, again, let me tell you, please do all your hormone measurements only in the morning. We can't be giving an antagonist and then doing an LH test. So do all the levels. So before the lady takes even vaginal insertion of progesterone, tell her take the progesterone measurement. If she has taken the vaginal insertion of progesterone, come to you after 2 hours, you're doing serum progesterone, it's going to give us a higher report because that will be reflected. And we don't use no, forget it. Yeah. So low serum progesterone level before ET, this paper definitely said your pregnancy rate, miscarriage rate, live birth rate. As look at the left-hand bars compared to the columns on the right hand. So this is about the progesterone levels and the estrogen levels, which I have to tell you that low progesterone levels definitely affect. About high progesterone level, there is literature is not very, very clear about it. In my practice, I do not follow a cutoff for my high progesterone levels, saying that, well, I will cancel my cycle. I would still go ahead and do an embryo transfer cycle at that point. And thank you so much. I'm just stopping here. Thank you very much for allowing me all this time. I don't know whether I've complicated and confused you more because the presentation was quite longish.
So definitely, we are not confused. I think we have gained reasonably from this talk of yours. And how to put it into practice, we will be talking next time. In fact, I was thinking that until the next talk, whenever we are stumped with a particular case scenario, we will make a slide and discuss it with you.
Definitely.
Discussion next time.
So next time we won't go back to these evidences because we have discussed it enough, and discussing a lot of theory is a little boring. We will go to the practical aspect of execution, the program, our FET cycles.
So your protocols, whatever you're doing, you can tell us. And at the same time, it's clinical situations where we find difficulty, we will also bring to this forum and take your advice on that.
I'm sorry, this might have looked very theoretical, but I just wanted to put all the evidence.
No, but then evidence is very important. I think having this background and then going on to the practical part is a very good idea.
And thank you, lovely madam. You really agreed to that proposal very fast to me. And thank you so much.
Because going slowly and steadily is, I think, the right way to go about it, rather than just rush through it. And that's why I took the liberty of telling you to go slower this time, so that we can kind of absorb it. And then I think a lot of us will be sitting down with the recording to listen to it again.
Even I need the recording.
All those. Yes, we will definitely share it. The IFS will give us the recording and I'll share with you. And then we can, kind of go through it again. So looking at the questions, there's one question: is excess of compaction bad for implantation? I don't think you said that at any time. If after compaction and ET is less than 7 mm on the day of embryo transfer, should we cancel it? Again,
I feel no, my message is don't look at compaction. That's a real message. Don't even bother to look at compaction. So
most of these papers will talk about.
Yeah, that's why I gave a systematic review. I'm saying that compaction is just, and all the studies are flawed. The Robert Casper study, let me tell you the flaw in the Robert Casper study. In his study, the day of embryo transfer ET was measured transabdominally.
This is what I was just going to mention. You cannot compare a transabdominal measurement with a transvaginal.
And then he quoted
that's a very major flaw in that
1
study.
millimeter. That's the biggest flaw. So I think compaction is something we should just forget about compaction. Don't even look at it.
Okay, so a lot of people got stuck with the endometrial compaction, and the answer to all those questions is that you
Yeah.
can stop worrying about
Stop
it.
worrying about it. Yeah.
So, is there any upper cutoff for progesterone levels that you follow, sir?
I don't, but sometimes now I'm surprised that sometimes I get a real outlier progesterone. I'm not expecting like the follicle 16 millimeter and progesterone level comes 65. I'm a little worried whether it is a truthful. Sometimes there could be assay problems. So I do repeat an assay as well. Or she could have taken a progesterone and then you have done a progesterone level or something like that could have happened. So
Yeah, that is an important
so when
thing
you do
that when you are
progesterone, very, very
assessing.
important. So to avoid these outliers now, which is streamline. That streamline we will definitely discuss next time. How to streamline our day of FAT.
Right. And what about aqueous progesterone?
Yeah, in the sense we don't give intramuscular at all. We all give aqueous only, and there are enough studies to say that aqueous progesterone is good enough. So don't worry about it. We give 50 milligram aqueous.
So you give vaginal plus
Aqueous. Vaginal plus
aqueous
aqueous or
subcutaneous?
vaginal plus duphaston. That's
Or
all.
vaginal plus duphaston. Okay. So then compliments, excellent presentation. And somebody said listening to you is like music to our ears.
Oh, no, no, that's not nothing. I'm just putting forth the borrowed data and borrowed publications from people. I'm just putting it up to you.
Then how often can we give parenteral progesterone during embryo transfer?
I think let's keep this question for the next time because we're exactly going to discuss these things next time.
Proluton injection.
Yeah, I think we'll keep these questions for the next time. The Proluton also. Yeah.
Okay. So I will have a lot of questions next time, sir.
Yeah.
This time,
Thank you so much.
think
Thank you.
It will be a great idea to all those. If you could share the
Papers, I'll send the papers.
Good, because they are the best, the selected ones, and we would love to go through them ourselves too.
Yeah.
And any other questions or comments from the chairpersons?
Kamla sir, Neela ma'am, Mahajan sir.
When is the next talk going to be?
We are going to have it in July. We are skipping June because a lot of people will be holidaying, and those of us who want to listen to Dr. Kulkarni, we don't want to compromise.
Okay, because I wish you could just go on. Yeah, it was lovely. Yeah.
Yes, because certainly not having a long gap would be nice, but then I think July a lot of people are going to be, not in town, holidaying at different times. So we've kept it for July. We'll definitely let you know.
July will have to just skip the X-ray time.
Yes,
it's given so much clarity. Yeah. It's given us so much clarity. It was very, very, very nice.
Thank you. Thank you so much. So feel humbled, man. Thank you.
So, Dr. Surjit, in case we don't have any other comments, can you?
Now, definitely, we should say the vote of thanks. Respectable Dr. Sachin, sir, seniors, juniors, and all the viewers on this virtual platform, a very good evening to all of you. It is my proud privilege and honor to thank you all on behalf of Chandigarh, Punjab, Haryana, Himachal, and Rajasthan chapters of IVF. We are thankful to Dr. Sachin sir for such an elaborate and enlightening lecture. He had made many points very clear and about the hormone levels and endometrium and endometrial preparation and embryos, because this is the most crucial point in the IVF cycle, the embryo transfer. All the hopes are there on that day. So we are very thankful to you, sir, for giving such great points, and we are taking many important points with us. And thank you to all of you for this on this virtual platform for attending this webinar. Thank you, sir.
Right. Thank you so much, everyone. And then we meet again in July. We will let you know the dates well in advance. Thank you so much, sir.
Thank you so much. Thank you.